Welcome, everybody. This is April 2026. We're going to be doing a BlockHeads episode on the ankle with Bob Stenberg. So I'm going to not waste your time anymore and let Bob take over as he talks about ankle blocks. Thanks, Bob, for coming in.
Just hit a button. Hold on. Cool. Well, thanks for having me. I am very excited to talk to y'all about this. Let's jump right in. Can you all see that okay? All good. Cool. So let's talk about owning the ankle. I think ankle blocks are really fun. I can't remember the last time I sedated an ankle, and I think these are good to talk about. And so my goal is to kind of try to, go through some of the basics, kind of maybe sneak in some pearls, but then I also kind of want to do some more discussions to kind of see how y'all are approaching these ankles as well, because we have some awesome people in the room to kind of navigate that. Here's our squad. I'm gonna skip through that. So, why should you block an ankle? Thanks to the pit, now it is expected that you block an ankle instantly in the trauma room. So, I think it's kind of a really cool how they have highlighted some nerve blocks on the show, and the pop side came up on there, so I had to make a shout out for that. But let's kind of go through some stuff. So, just a quick case here that we had recently, just a casual ankle roll that looked really sideways. So I got a nice popliteal block there, and then a below the knee saphenous. And here's our post reduction, and then the later fixation. So kind of a cool navigation here. So the ankle is complex. There's a lot of moving parts. There's a lot of different nerves that factor into this, primarily four different branches. But there's a lot easier way to look at this, and there's two big targets here. You have your sciatic nerve, which does a huge chunk of it, and then you also have that saphenous nerve catching that medial aspect. So I'm gonna start off with I'm gonna kind of basically break it with these two parts. So starting off with the sciatic nerve, here's our dermatome, myotome, and osteotome of the sciatic. And you can see this is a huge coverage, right? Because you're getting your tibial, your peroneal, you're getting all these different nerves stemming off that sciatic nerve. So you get a huge coverage on this. So there's a lot of reasons you can do this too, correlating with all those different nerves. And I mean, I think the primary reason I'm doing this is really for an ankle joint. And you can also do it for locks, etc. But I feel like I'm primarily doing these for ankles. So both of these blocks, your leg is long and the nerve is long. So there's a lot of different places you can block the nerve. Here are the three main spots you can block the sciatic nerve. And so here's a shot at a transgluteal sciatic. I don't have a subgluteal sciatic, and here's a pop. And I don't know how y'all are operating, but I kind of look at it as, they either are, they have a sciatica and they're going to get some D5 with a transgluteal, or they have something else in their lower leg and I'm going to go to your popliteal. So that's kind of how I'm approaching these, and I feel like a lot of other people are approaching it in a similar way. So I'm going to try to focus on the popliteal sciatic real quick. I always like to go where you know, and you know your right where your popliteal DVT evaluation is, that sciatic is sitting right on top of there. So it's kind of right where we know. Here is an infographic for that. So you kind of have that probe posterior in this shot. You're finding the nerve sitting right on top of the vessels on that near field. And you'll kind of see as you sweep them down, you'll see, the initial branch being the common peroneal and that tibia off that locus sheath. So that's what we're going to kind of be looking at here. Uh, really, really huge pearl is you have to make sure you see the peroneal nerve. If you block it distal to where the peroneal nerve is, you're not going to get any coverage. You're going to completely whiff on that labrum malleolus. And I've done this before, and it is sad. So I encourage you not to make the same mistake that I did. So you want to see, you want to be able to sweep up and down with your probe to make sure that you're actually seeing that peroneal come and attach to that spot to make sure you're actually catching the peroneal. An alternative thing that you can also do that I've also done is along that posterior aspect to kind of just put the probe about where I think the fibular head is. You know the peroneal is going that way. And then you can sweep up, find the peroneal, and see join in with the tibial to get your sciatic, to kind of get your area, because you cannot miss the peroneal, or you're going to kind of whiff this block. And there's, in the past, people were kind of just blocking the popliteal sciatic before it even bifurcated or split off at all. And there's some good anesthesia literature now that kind of says you kind of want to go just after where it branches off. So if you're kind of looking at it being, some pants, it's kind of like right in the crotch of the pants, which is kind of a Mikowski saying there. But so we're really kind of going just so that we're seeing it just split off, and there's often still in that locus sheath. But in all the anesthesia literature, when you go just after they really start branching off, usually have faster and more reliable coverage on that block. So that's another big pearl there. Here's just another example of just doing one for, a horrible foot fracture. There's a lot of different ways to block this bugger. Here's a couple different approaches. And one other kind of thing that happens, especially in the ER, and when someone's ankle is mangled, is they don't feel like laying prone to get into position to get to block, to put the probe in the popliteal fossa. So you got, I saw Goldsmiths on here. So you got some people that talked about this. And this is talking about the CAPS block. So this is actually putting the probe, along the side there to access the sciatic nerve without having them having to flip over, which is really nice. And you can also go out of plane on this as well. Sorry, I can't make that screen share thing go away. I apologize for that. So moving on to the saphenous nerve. I think this is where it gets tricky and this is going to be kind of be a little bit more curious to see how people are approaching this. So the saphenous nerve is literally just the sensory distal branch of the femoral nerve. So it branches off kind of like right near that femoral triangle as part of the posterior division. And after all the nerves of the quads kind of split off in that posterior division, and then the saphenous goes all the way down the leg, and it's purely a sensory nerve. So because of that, you can block that femoral along different sections. So why doing a saphenous? I mean, largely still a lot of ankle stuff. We also had a really bad medial calf lack recently that we did a saphenous block on as well. And then anesthesia is using this a lot more for like knee pain as well and knee surgeries. So this one, there's even more different places that you can consider blocking this because it's also just a part of the femoral nerve. So you could straight up do a fascia iliaca and you could do a femoral. And so there's the adductor canal and that saphenous below the knee are some other kind of more dedicated saphenous blocks. But because they're part of the femoral fascia iliaca, you in theory could just do those. So here's just an example of your fascia iliaca. Here is kind of your femoral nerve. Here is an adductor canal. And then here is kind of an example of getting it, just around that tibial tuberosity in that kind of like infrapatellar type region to get it next to there. So just kind of quick talking about nerve injuries, and this gets a little bit controversial and messy. By far and large, low injuries of nerve rates, but there's some increasing kind of, murmurs and stuff regarding the adductor canal. And one of the concerns is that with the approach that you take to get to the adductor canal, that you can, skewer or contact the nerve to vastus medialis. And Duke Regional Anesthesia talks about getting some atrophy associated with that. And there was also a 2025 article talking about rates of kind of more chronic neuropathy related to the adductor canal, which is a little bit messy and kind of in the setting of surgery. And is it really from the surgery versus the block? But it's a little bit messy and in the air right now. So here is your adductor canal block. It's going to be about 10 to 20 mLs. And you're going to try to get under the sartorius to get where they are. And again, right where we're going for a DVT eval. Wherever you start doing DVTs, you're just going to start seeing nerves everywhere as you do this. So where is the adductor canal? The adductor canal is the distal portion relative, it's right after the femoral triangle. So it doesn't really matter, and it's kind of gets involved in semantics. The higher up you are, the probably more likely you are to get some motor blockade with it. But if you look on the right side, you'll see on the top, you'll see the adductor and the sartorius are kind of almost like kissing together. And then as you go down the leg, the sartorius runs over the top of it where they're still kind of more adjacent to each other or kind of forming that corner. That's kind of the end of that femoral triangle versus the adductor canal. But you don't really need to know that. All you need to do functionally and how a lot of different resources will reference this is you take the superior edge of your patella, take your inguinal crease, split the difference, and find the vessels and go for it. So I don't have a good way to look at the room or raise hands, but how many of you have came in for an adductor canal and you dump anesthetic deep to the sartorius and you get a bad block? And I think one big reason why you get a bad block on this is because of this vasoadductor membrane. And it's supposed to be a pretty thick membrane. So if you don't really get into that membrane, you're probably not going to get that good of a block. So a lot of different references will talk about actually getting through that membrane. You want to see that the anesthetic surround the artery or even kind of like push in the artery as you're instilling the anesthetic. So that's kind of one thing. And I've had a couple of these. I'm like, what the heck happened? I had this beautiful fascial spread deep to the sartorius and didn't do jack squat. So I think you kind of really have to see that fluid spread around there to get a reliable block in this area. And this is kind of one other thing in terms of this whole nerve injury aspect is there's that nerve to vastus medialis running along there. I may or may not have had a adductor canal block to kind of just see what it felt like. And I had some pretty impressive quad weakness from it. So I got the vastus medialis on this, but there's some thought too that you can literally just come out of plane to avoid the nerve to vastus medialis. It'd be even tough to visualize on ultrasound. So by aiming just right next to the femoral artery and watching that fluid and stone there, you're kind of getting away from the area where the nerve to vastus medialis is. And so it's kind of supposed to be like a bypassing thing. A lot of times anesthesia is trying to also catch the nerve to vastus medialis because they're trying to get some knee coverage with this. But if you're doing this for an ankle, you don't give a rat about the nerve to vastus medialis. Last block here is the going through the saphenous nerve below the knee. And so at this point, the nerve is a lot less juicy. It's a lot smaller, and it can be really hard to actually see on ultrasound. So if you read some things, this actually used to become more of like a field block. So they just basically come right near your saphenous nerve and the greater saphenous, and just basically you dump a bunch of anesthetic in that area. So, but you can sometimes catch on an ultrasound. We kind of just go through this. This is kind of a sweep through that distal area where you can kind of make out a little tiny bugger along that saphenous nerve. And someone has their mic on. So this is kind of one of those techniques you can do. So if you're not picking up that GSV very well, you can also throw a tourniquet above the knee to kind of help make that GSV kind of pop out more and just kind of showing the tourniquet there. And this is just again showing some, you're basically just aiming right next to that vein and watching fluid spread around there. And sometimes you can kind of help see that. So, kind of to wrap things up, some quick good pearls. The pop psi is an amazing block. You should get good at it. Please do not miss the proneal because your block will suck and everyone will be sad if you do that. You want to go just into that bifurcation to get a faster onset and a more reliable block. And then if you're trying to really jump around that that challenging position when someone's ankle is mangled, a caps block is a great approach. For the saphenous, so many different ways to approach it. And I mean, honestly, too, I think you could argue instead of teaching a new person a block, heck, just have them do a fasciaca or a fem. And also, too, if you're trying to reduce an ankle, having quad weakness is not the worst thing. And they're going to be non-weight bearing on the leg anyway. Kind of don't care about them having muscle weakness. The muscle weakness related to the adductor canal is a lot more focused on anesthesia when they're trying to get very early mobilization. This person is going to be non-weight bearing for their destroyed ankle. I don't care about that. And especially if you're trying to, get, some good like reduction on if it's a tube tailor dislocation, having the quad being out may not be the worst thing in that scenario. But by far and large, the most literature on the anesthesia side really kind of supports going for the adductor canal and, um, you know, just making sure you can consider going out of plane and then really trying to getting that arterial fluid. So I kind of want to jump into some discussion here at this point and kind of say, I think one of the big questions for like, I mean, we have some experts on here. What's your approach to this? So it's a pop side plus what? Are you doing a fasciaca? Are you doing a fem? Are you just dumping a little like hematoma spritzer in there with it? Like, how are you approaching this? Does anyone have anything that they would like to add?
We actually just did that this weekend. We ended up doing a popliteal and an adductor canal. Um, and the main reason for the adductor canal was because the guy had a huge laceration at the medial aspect of the ankle, and the pain was not controlled with the sciatic nerve block in the popliteal fossa. So, and I agree with you, the approach is usually the biggest limitation too. So we were able to get the probe underneath the thigh too, so the guy could just lift it. With the caps block, I have really struggled with finding the landmarks using that lateral approach too. So we just feng shui the extremity and do it that way.
Yeah, a little bit old school here. I think we still use a lot of intra-articular hematoma blocks for relatively uncomplicated, like a straight dislocation or a trimal with not a lot of malposition of the bones and a relatively simple splinting. It still seems like it's still faster and works as effectively to do ultrasound-guided intra-articular hematoma block, and then for the more complicated ones or ones with lacerations, we'll go ahead and do the higher blocks. I know how many people are still using hematoma blocks, but the literature is pretty compelling that there's not a dramatic difference for the less complicated
I
ankle
have to,
injuries.
I have to fight orthopedics to get in there before they dump 20 cc's of local anesthetic in there too, and then they just kind of shoot us in the foot a little bit because they dump a massive volume in there. So I'm like, okay, let's do some math.
Is anyone routinely using the caps? Because I really haven't not done a lot of that either.
I've done a couple. They work well, but it's I would agree with Kat though. I feel like half the time the mental gymnastics of finding the anatomy, it takes me an extra couple seconds to find it. But I've done it on a couple folks that truly we couldn't feng shui over under their stomachs.
But like even turning them over on their side, that seems to work a little bit better. So if they're in the lateral decubitus, I can work with that. Joseph, I think you're on the call right now, was just subjected to doing the upside down of probe gymnastics in his head, and he did a really good job with that. But the caps block, I struggle with finding the landmark sometimes. But usually by the time I do the pop psi, it seems to cover most of the pain from the bimals or trimals, unless there's a large cut at the medial aspect of the ankle. So even if I just do the popliteal block, that provides enough osteotomal pain control that, and or coverage, I should say, that they seem to be okay. Only if there's like very rarely do we have to supplement with an adductor canal.
It was a little bit crazy, almost like an experiment. I may or may not have tried an adductor canal on one side and then try to blow in the saphenous on the other side and try to just like feel what it felt like to compare them. And I was kind of amazed on my medial malleolus. The coverage on it really wasn't that good. It was kind of more in the superior aspect of my medial malleolus, but on the inferior aspect of my medial malleolus, I still really had a lot of sensation. So it was kind of surprising.
Huh.
I had a decently dense block over my calf and everywhere else.
Wait a minute, you did this to yourself?
Something like that. May have given some learners some opportunities or something. I don't know.
So was that the saphenous that was less dense than the adductor canal, or vice versa?
It felt honestly really symmetric. I think I got a little bit lucky with that, but I was just really kind of surprised. The osteotome on the medial malleolus with the doctor just really wasn't like the inferior aspect. Like it still kind of really feel everything.
Nice.
Have any of you done just like a fem or a fascia iliaca with a pop for an ankle? Because I haven't, but I mean, it seems reasonable.
I would never do a fasciitis for that. The reason being is if I'm going to bimals and trimals can technically go home. And so like as long as it's not an open fracture, I guess, but I want them to be able to block out with not on the leg, but like be able to have some motor function of their thigh.
And I was kind of thinking they're going to be non-weight bearing anyway, so that's a fair point. But I was like, if they're non-weight bearing, does it matter if their leg is out anyway? I definitely get that point.
I have done hematoma plus off plenty of times though.
Yeah.
Mainly hematoma for immediate relief and reduction, pop for long-term relief.
So you do the hematoma block with the lidocaine and then circle back and do the popliteal.
Yeah,
Okay.
because I can reduce really quickly with a lidocaine, splint, well, do the popliteal, then splint,
Okay.
and go from there.
I see. That makes sense. Yeah, we literally just tried to do that on an 80-year-old, and then we already walked into just this clot of orthopods, and they're already pulling on the ankle. Like, oh, foiled again.
That's what a collection of orthopods is called.
The communal noun. We were just discussing that. We're going with osteoblast or growth plate.
Oh, nice, nice.
It's always nice to
Just
call them after the block of reduction and have them come out and clean up.
just for like those who might be watching this later on, just want to be clear about um being careful with concerns for compartment syndrome. So if there's like a Mason-New fracture, if there's concern for syndesmotic disruption and high risk for compartment syndrome, crush injuries, all that sort of stuff, this is something that we would, have a conversation with ortho ahead of time prior to doing a pop sciatic. So I just want to make sure that we put that in there before going on.
I'd also offer, Bob was talking about doing the sort of the pants block and catching right after or right before the bifurcation. I would say depending on the level of learner and the a degree of needle control, that adds a slightly higher risk for causing peripheral nerve injury. So adjusting where you're doing the block, it'll take a little bit longer and it's a slightly less dense block if you do it where it's still the sort of distal sciatic, but is a safer target potentially.
Sorry, I forgot to mention, I also just threw in like a Google Drive with some references and some figures there too, if you wanted.
I took you off the screen share. You can re-engage if you want. Quick question for the group. I've heard arguments for both being outside the pants and inside the pants for the pop sciatic. Some people say safety, some people say efficacy. Any comments on that?
By inside the pants, you mean like inside of the MasterCard sign? Like inside of that little fascia layer?
Yes.
Yeah, no, I typically try to get them as up close and personal to the nerve without shish kebabbing the nerve itself. So, and I usually feel like a little pop in there too. What I've also heard is that if you actually get it into the fascia, the containment of the local anesthetic within that fascial sheath prolongs the duration of the block by virtue of the local anesthetic sitting inside of the pant legs, if you will. But yeah, we typically aim for that 6 o'clock position on the peroneal nerve, and that seems to kind of be the safest approach a little bit.
Yeah, that was similar to what I was taught as well.
But the biggest barrier for us is actually orthopedics too, because we sort of have a little bit of an agreement. And just now, after years of doing their hip locks, they started feeling comfortable with us actually taking out the lower leg for these injuries too. But they get a little bit squirrely about compartments too. So this is one of those where you can't just like make a unilateral decision without touching base with them. So
What would you say are some of like the highest risk, other than crush injuries and syndesmotic disruptions? Are there any other classifications, trimals, whatever, that you think fit into that category for maybe people who are thinking about starting this?
tibial plateau usually they don't want us anywhere near those. Like I've only had one ortho comfortable with it, but
Yeah, Kat. At Hartford, it's the same thing for us. Our orthos are completely fine with us blocking the hip, but for the lower extremity, they actually request that we don't do these popliteal sciatic blocks or any of the lower leg blocks because after their reduction, our workflow is that we consult ortho for a lot of the reductions because we are like a quaternary care center. We've done popliteal sciatic blocks outside of reductions for like bad lacerations or for other injuries or burns, but yeah, we have the same thing. Our ortho specifically requests that we do not do these blocks. They lean on hematoma blocks a lot, so.
yeah.
I don't know how you guys have gotten past it, but our orthos are like they're pretty open to blocks and they're relatively nice, but they're for the lower extremity, it is a stonewall for us.
Yeah, it took us years to get them there. It'll come, but ugh, it's not a hill I'm going to die on. Oh yeah, xylazine wounds too, if you have a contingent of that. I was just looking at the chat that the blocks are amazing for burns, foreign bodies, abscesses, and lacs. Um, we do have a steady trickle of xylazine customers, so it was great for that. That and maggots.
Sounds like you got a lot of fun down there.
Come on down.
Has anyone actually looked into literature recently on the concern for compartment syndrome masking with these? Is there a robust data, or is it still just kind of like case reports and garbage?
It's that trash can, the lid on that trash can has not been opened up in a while.
Yeah, because I have a buddy who does a lot of motorcycle accidents in Kenya, and he uses bupivacaine. Just what he has, and indicates that for most of his compartment syndromes that they break through the block, and that he has pretty robust catches related to that, and has to keep these patients for multiple weeks because they don't have robust ortho access. Just put them in traction for weeks on end while they heal. So it's a rough situation, but he does a lot of the pop sciatics to get them through the pain of that, and so that the nurses they can have higher nursing ratios, because the nurses don't have to give IV pain medications quite as frequently. So they really like it when he's able to do that. So I don't know if there's any real good like objective data that has come out. It would be nice if that did happen. So just for anyone who's thinking about researching that, that'd be great.
The other time I've
How are you
used
gonna get
it,
IRB approval?
yeah, right. The other time I've used it was in Wisconsin. You couldn't have the same person do a procedural sedation and a procedure, so you had to dual docket. And so I would do the block, go see somebody else, come back while the block was still working, do the reduction, splint everything, and just do lidocaine so that I could do a post neuro check and then discharge. That was sort of my like 2 a.m. workaround as opposed to waiting until 6 a.m.
Makes sense. All right. Anyone else for thoughts, comments? Bob, thank you very much for presenting on this. I like the great graphics, great conversation, and really need to start using pop sciatic probably more in non-orthopedic cases. So thank you very much, everybody. Great week. We'll be having another session deeper in the summer. We're going to start moving towards once every 3 months for these sessions, and try and have really robust conversations. And if you want to talk about something, feel free to reach out. Otherwise, we'll see you on the next one. Have a great week, guys.
Thank you.